Welcome to the Framework in Focus, a videocast series where we provide insight into our ebook titled Musculoskeletal Clinical Translation Framework from Knowing to Doing. This name is a mouthful, so we'll hereunto refer to it as the framework. We hope this series will complement the ebook and provide additional insight into the whys, whens, wheres and hows of the framework, and this goal aligns with our ongoing efforts to facilitate knowledge translation in the management of musculoskeletal pain.
Well done, Darren.
I had to do it properly once. Yes, number 11, functional behaviours. So looking forward to getting into this. I am Darren.
Tim.
Pete.
And Helen's not with us at the moment, but we're the co-authors of the framework here. This is our warning slide where we are talking about functional behaviours right now, but that's artificial in terms of the way that we understand the whole person perspective and all the elements of the framework linked together. So we like to make that clear as we talk about the individual elements. All right, so we have a quote here from Marilyn Monroe of all people. I have evolved my own exercises for the muscles I wish to keep firm. And I know they are right for me because I can feel them putting the proper muscles into play as I exercise.
Wow. Yeah.
Yeah, pretty insightful. And looked at this a little bit, and she had actually devised her own exercise kind of program. She was her own trainer, but there's some real insight into that in terms of understanding and knowing how her body works. Something we're probably trying to get our patients to understand a lot of times.
Yeah.
Okay, so Tim, this is again a cut from the app.
Yep.
So it's pretty similar to what's in the framework itself. Do you want to?
Yeah, we'll talk a little bit around this. Obviously, people, hopefully having read the ebook, would be pretty clear on this. One thing to mention at the start is we've got this term functional behaviours, which we did spend a lot of time trying to work out language, and the traditional musculoskeletal assessment involves a physical examination, and there was lots of talk of, well, you haven't shown your physical examination in the framework there. Where do you physically examine people? And the real main physical one in there is this functional behaviours. I've got plenty of thoughts around that. Do you want to start with any, Pete?
Wow, it's such a big question because it's been a huge part of my clinical journey, I suppose, where at the very beginning of my journey as a physiotherapist, I worked both in neurology and in musc.
Yeah.
And neurology was so much about behaviour, movement, and musc was so much about specific tests and muscles. And it was a human being that was, in each case.
Yeah.
And it kind of seemed like there were these different languaging, but it was the same, movement system that was being assessed. And I think the thing that has struck me more and more, having worked in clinical practice for, more years than I want to think, is that often what we see, I used to interpret certain things in movement as unstable or dysfunction or whatever, but it often is a manifestation of someone's response to pain or their levels of fear or anxiety or their worry or their distrust or lack of confidence in a body part, or that is manifest in the way in which they behave.
Yeah.
And so this idea of looking at movement as a behaviour, I think, is so helpful because it feeds into all the aspects of the framework.
Yeah.
So instead of it being this isolated, I'm going to do the physical exam, this is now about exploring the person's story in their own body.
Yeah. I
It's
think
the embodiment of their thoughts and emotions.
And I think previously, as we've tried to get better at understanding musculoskeletal pain, we've drilled down into all these individual tests and what's the specificity of each test and how reliable or valid is that. And personally, I think I got lost in that for a period of really trying to drill down. But my background also was neurosurgical, so acquired brain injury and then musculoskeletal. And when I reflect back on that and some of my early mentors, they even said to me as I was progressing along, you're kind of really looking quite narrow there and, drilling down on that detail. But as you said, understanding that how someone functions is reflected in all the different elements of the framework. That's why we talked about functional behaviours, and behaviours isn't just how you behave, is it? It's you know, it's all those components of how you respond to different stimuli and how we see people moving and functioning. But that comes back to the start, the individual's perspective of what can and can't they do, what are their limitations, and we need to be conducting our assessment based on that, and that's where the story bit, I think, comes in.
Yeah, I think it is a good question, like where do the physical tests fit in the framework? I've had the same question about where does neurological screening fit in, being that that's a pretty important part, but clearly then that fits into the diagnosis label, and maybe you could think of the other clinical tests fitting into the diagnosis label as well in a way. If you try and look for a structural component to the pain, then they kind of do fit there, but they can fit in this part as well, because you're still trying to provoke symptoms. Totally.
I think they do. You have someone who says, look, I've got pain when I walk, and they walk with a limp and they've got a dropped foot, but you need to do a neuro.
Yeah, exactly.
Like, so that observation, acute observation, draws you into.
So this is intentionally labelled, you're here to assess this person's functional behaviours.
Exactly.
And you can or cannot choose to drill down depending on where the story unfolds. So that's where we've got these parts where we talk about the different behaviours, and they're broadly put into movement impairments and control impairments, and we can argue back and forth around, you know, is that the right language still? But certainly to look at the case examples around that in the ebook and understand those, and then we talk about the pain behaviours, and then also general deconditioning. But that broadly, if you look at the examples, does cover off on the different clinical presentations that we see, and I think it still remains helpful to look at them in that context. And then the second part, which we'll also talk about, is the health value, so how helpful or unhelpful are those different behaviours.
Which looks like that in the app.
So I keep this in mind with my initial questioning of listening to the stories of the person's describing their problem. And let's say they've got a knee pain, and they'll often talk about not being able to tolerate weight bearing on that leg. And early on, we need to decide, don't we? Hang on, are they avoiding weight bearing because there's tissue pathology there that they need to offload to allow that to settle down, versus were they initially avoiding weight bearing for good reason, and now do they have those catastrophic thoughts of their knees crumbling so they daren't weight bear? And that becomes a product of now they can't recover because they avoid that. So that could be an unhelpful behaviour.
Maybe actually these questions will work quite well as triggers for the conversation going forward now. So the first one's around integrating this into the broader biopsychosocial perspective, and Pete, you know, you've done a lot of work in this.
I think behaviour is so interesting because we know pain massively disrupts movement behaviour, and the tricky part for us as a clinician is to go, is this an underlying is this biological? Is there pathology? Is there a fracture? Is there a disc prolapse? Is there a tumour? Is there, some bone edema? You know, is there a clear biological driver for that? And I can think of numerous patients where there absolutely is. And so the protective guarding is a good thing. It's normal. It's normal to guard a joint when it's fractured. It's normal to guard your back if you've got I had a fractured back and a fractured wrist, and God knows what. And I had no control over that muscle guarding, and it was a good thing. So we cannot look at just at movement and then ascribe meaning to it. We need to go through the whole process and listen to the story, get a good history, and consider all the factors to triage the person, because we could be treating something that we shouldn't be treating otherwise.
Which does happen.
And from that perspective, then your examination is open. And I think it's so important that you're exploring, you're testing hypotheses, and part of that hypothesis testing is this a helpful thing or not? And you're to a large degree, your story will help you with that. But there are some cases where you literally have to explore. And it may be that as the person relaxes and normalizes their movement, it makes them worse. And you've got to be thinking, what is going on here? Because in that situation, the behavior itself may be protective and helpful. But if, as you, a great example might be if someone who's very fearful, guarding may be really unhelpful if the basis of their fear is not actually real, not true for that problem. So they may think that, relaxing and bending will prolapse their disc, and actually relaxing and bending feels really good for them, and it relieves their pain because it's a normal, healthy thing to do. So you can test that gently and gradually in your examination to kind of sieve that out in that process.
It makes me think of, you're describing, and we call it functional, and you're describing a functional way of looking at people. And for lots of practitioners out there, they're taught a more muscle-based kind of approach. And, we've all worked that approach and evolved beyond it. And there's not a manual for that I'm aware of, unless have you finished your book? Or
That's a good question, but I kind of see that the patient brings in their manual. So the things you're interested in are the things that are important to them. So they bring their they personalise their manual, because you say, well, what do you have problems with? I can't sit, I can't stand, and I can't walk. Well, lying them down, but our sleeping's good. Why are you lying them on the plinth? Because that's the bit. Unless you want to look at how they relax or a position of ease. But so often we get so fixated on special tests, which aren't special, by the way, because they're not usually valid and they're not very predictive. And we assess things that are not even relevant to the patient's problem. And it's a massive red herring for us. Because I think we get caught up in complexity, trying to do a whole lot of tests, and we've forgotten the patient's story in the middle. And I think understanding that the patient brings in, so I would always say, what can be helpful is using the patient-specific functional scale to go, tell me the 3 things that are most limiting for you. They are the things that I'm most interested in. They are the things I'm going to target my examination. To me, it tells the patient you're really interested in the things that are important for you.
And I think we've talked about this before, but when we look at educating, particularly physios, which is mostly what we've done around the clinical skills, we teach physiotherapists to be highly skilled at screening for. So if you're talking back leg, how do you screen in or out the lumbar spine or the sacroiliac joint or the hip joint or neural tissue? So you might need those individual skills, but does every patient with back leg pain get those? No, they don't. They start with perhaps the functional complaints as a really good starting point, and then you're drilling down, this person can't bend or can't squat. Is there a restriction of movement to that? Is there a strength issue to that? Is there some neurological component? Is it pain? But then broadening beyond that is the elements of the framework, like we've said in a previous episode around their beliefs. If someone believes when they bend that's going to cause trouble, they might look stiff and tight. You can stretch them out and massage them all you like, but that physical embodiment, which is the mind-body relationship bit there, that may be the major barrier.
I think, in our manual therapy training as well, we were probably originally taught to think of the body as these motion segments, right? And I can think of numerous times where you look at someone move or listen to their story, and then the therapist is trying to feel what's happening at this segment, which we know we can't do reliably, and no one can agree on it. And we're making a judgment on someone's whole clinical course based on a test that's not reliable, that we can't agree on, and we've forgotten all the other big stuff. That's a real limitation of physical examination, where it's not person-centered, I think, or evidence-based.
Yeah, excellent points. The mind-body relationship you touched on there, and it's just so important to understand this connection between mind and body. There's a lot of really interesting work around that in the literature, and then I guess it does go into this behavioural experiment kind of approach, and trying to get the person to get their brain and body working together. Do you want to explain a bit around the behavioural?
So probably the first part of the behavioural experiment is to be good at watching. So I often say you have to be a great communicator. you have to have a framework, which is what this is, and you have to have really good eyes. And then we'll talk about touch a little later in this piece. But that ability to watch, and often we go, oh, the examination starts when the person, is driven down. No, the examination starts when they walk into your room.
Yeah.
When you shake the hand, if you're allowed to. In COVID times, it might be that. But when you're talking to them, are they at ease when they said their facial expression? So the observation is, the face is a massive window to the person's mind. And so looking at body language, facial expression, ease, comfort, ability to move, posture themselves, etc., that becomes a big framework that you're starting to collect data already as you talk and chat. That's going to start informing the next step, which is to look at function and to then explore the things that the person can't do. So, for example, it may be that the person has the greatest fear or functional limitation is to step down off a step if they've got knee pain. And that's a really scary thing for them. You may not go to that first.
Yes.
And I think that's where you have to be really careful, because if the person's really frightened, you can frighten them off by going straight to the most threatening thing. And that's how you have to judge that person's level of distress or fear, that you grade into it. And so we talk about graded exposure, but also we need to grade our examination, that we're not, that we're sensitive and aware of the person's level of comfort and worry and fear, that we want them to feel safe in our presence.
Yeah.
I think that's a real clinical judgment, as you say, based on the story. And I think we often talk around this to make people aware of it and be cautious of it, but it still is a spectrum of that, isn't it? Because some people, there's none of that and you can go straight to it.
Yeah.
But you've decided that because you're a skilled communicator and you've listened to the story, as opposed to others where you're going, there's no way I'm going to put them on a step.
Absolutely.
Straight away.
Yeah. And so you might say, let's have a look at get out of the chair, and they don't use their leg. You go, so my first thing was, did you use both legs? And usually they don't know. So one of the things about human behaviour is people often don't know what's in their body. They're acutely aware of their pain. They're not aware of their behaviour. And this is the mind-body thing. It's so interesting because they're thinking of their pain. Their pain's got a meaning or what it is that, or a level of the emotions that go with it. They don't know what they're doing with it.
No.
And so what would happen then if you did use your leg? Oh God, that's going to be terrible. Okay. Do you know that? Or is that something you think? So you then start unpacking. What would you think would happen if you did use both legs to come out of the chair? That's going to be terrible, okay? Are you confident you could do that? No way. So then let's move on to something else. So that might be something I come back to when I've examined that person more thoroughly. And so you gauge that sense of confidence, the beliefs around that movement, that you can then touch in. So you might then put them on the plinth and go, let's have a look how your knee's moving, let's strip of that. So you may use those tests to basically start to reassure the person that the knee's actually quite mobile, and it gives, it's quite strong there, that's cool. Let's come back to this in a slightly easier way and recheck that.
But that's the skilled clinician of having the communication, but also the toolkit around knowing exercise and function, and go, well, I'm not going to do it out of here, but I might raise the plinth so it's only a much lower effort, and then progress it down.
And let's use some support with your hands. Let's just try it out, because I'm really interested to see what happens if we change something about that, and then be respectful. So we know where exposure training goes terribly wrong is where the person's anxiety or stress or fear elevates, then their pain will often escalate. When you can dampen their sense of distress and fear, often you'll see pain dampen. As long as there's not some underlying pathological process.
And it's very much like the framework itself. It's highly flexible in terms of where you start, and it's iterative and educative as you go along, and they're critical kind of components in there to make the person become self-aware and
and build self-efficacy. We talked about self-efficacy earlier, but self-efficacy around the body is embodied. You can't talk someone into it. It's a showing them into it.
And the hands-on, specific assessment is so valuable around that, where someone might look at us scan report and say there's nothing wrong with your knee and that's it, but where you've got in there, you've felt it, you've assessed it, and the person can buy into that far more.
Absolutely.
Far better. Excellent. So, behavioural experiments, and we kind of did move into then getting people to reflect on the movement and what they're doing. And assessment's clearly an education thing for you.
Yeah, totally. So, and just to pull out of the behavioural experiments, often these behaviours that are threatening are linked to thoughts and fears and emotions. And so explicitly ask, what are you thinking? What does it make you think? What do you expect? What's your level of confidence? Be explicit around that, because it starts to, and people may not give you anything from the interview, and they'll give you a flood of information during the behavioural experiment. And that is gold. So that's the stuff that then starts creating your framework to go, there's a whole lot of information I'm getting now. When I start looking at people doing stuff that they're having trouble with, that's really important.
I think for the clinician, going back to the helpful and unhelpful functional behaviours, obviously in this instance we're broadly talking around you've been able to modify that and there's been a positive response in terms of symptoms or how they're moving or functioning. Then it's quite clear that behaviour is unhelpful and we can assist change in that, and that's likely to lead to a positive outcome. Obviously, if we're doing that and the pain's getting worse, that's when our skills come in to go, right, let's assess that. Is there pathology or other reasons behind that? So I think that's really important around understanding that's where the helpful or unhelpful bit fits. And then let's assume that behaviour is unhelpful and they're with you on that. The next, I guess, risk point or potential error point for clinicians is then going, right, now we're going to give you a program or a home program of shifting this in how you're behaving. Do you want to talk to how that either goes wrong or how we can be more effective with that?
I think the critical thing there is that you shouldn't give anyone anything that hasn't been part of your assessment. So don't throw them a whole lot of stuff that's not related to your assessment, because they need to know that they can walk out with confidence to replicate something that you gave them that they knew they could do that wasn't threatening for them. Where that goes pear-shaped is you've done your exam, you tell them, like, now you have to go and do this. It's got nothing to do with my problem, and you've got to be explicit about how this matches to their goals and to that journey. So that when you start reframing this, you're going, let's recap what's going on here. You've had this problem for X amount of time, your story, you want to get back to doing these things. Your barrier, you've told me, is this knee problem is stopping you. And from what we've learned today, what have you learned today? Even better. Ask them, what have you learned today? I've learned that actually I can load that knee and it feels better, but shit, it's weak. So what does that tell you? It tells me I need to get my leg stronger. That's going to take some time. Is that something you would like? Because then it's like, it's their story, it's their goals, it's their experience that you're then building a story, a narrative around. Is that something I'd love to do that. So how do you feel about us setting up a little plan that Bill starts taking you on that journey? I'd love that.
And you've beautifully described their pain education. Pain education is not sitting in a room having a lecture about, what might happen. It's a personally meaningful journey through their experience and then trying to find a path forward.
The other thing that directs to, which you're really talking about, is a version of exercise rehabilitation. And Darren and I were teaching a course a number of years ago around functional lower limb exercise rehab, and Darren put together this really nice table that I think helped us reflect on. We talked about sets and reps that get prescribed for patients. And what we brought it back to is, what is this exercise for? And traditionally, this is a strength exercise or an endurance exercise, and there's clear parameters around that. What I've shifted to over time is thinking around, well, hang on, what's this exercise for? And it might be a functional exercise, but it might be much more around, as you're saying there, confidence, for example. So then the numbers that you prescribe become quite plastic, and in my experience that becomes an individual negotiation with that person. How would you?
Yeah, and just on that also then functional integration, what's an exercise and what's a new habit.
Yeah. So they can blend as well.
Yeah.
Because of course if you often see people who are like really fearful and avoiding loading a limb, and actually the more they engage, the stronger the leg feels.
Yeah.
That's very different than someone who's completely deconditioned, they'll fatigue rapidly. Yeah. And so that's a sign that speaks much more to central inhibition than it does to a deconditioned body part.
Yeah.
So as the confidence builds and the fear reduces, the central inhibition reduces, and they have a sense of more security, more stability. They can balance better. They feel stronger. It's like the system lights up, and that's a go. In my mind, that's a green light. Unless there's something in the story that's telling me that these people get a massive latent response to doing stuff, in which case be very careful.
Yeah.
And that's a delicate space to go in, and always tell people when you've done exposure work that you will get muscle pain. And it may be scary because it's in the vicinity of your pain, but it's okay, it's safe. And if you have a flare-up, contact me, because flare-ups, when they go pear-shaped, you'll lose your patient.
Yeah.
And that's about trust. So it's a really tricky line, because we know that with exposure, say for people who've got high levels of fear, actually, the bigger the discrepancy, the better the effect. So if you've got someone who's thinking that if I just bend over and I'm going to blow my back, and you can get them to bend over and lift a weight, that discrepancy, oh my God, I haven't blown my back, can massively reorientate the way they think. But if they did hurt their back, it will massively reinforce that was a really bad idea. So that idea of being very delicate and sensitive in terms of the way you work with someone and how you dose their exercise. You may give tiny doses at the beginning where there's a story of like a major pain event with minor activity. Maybe just relaxation in day one.
Yeah.
And it all comes down to that whole framework of understanding pain mechanisms and underlying emotional and cognitive processes.
Deconditioning, you mentioned, is one of the factors in this element, and it always surprises me how far a lot of physios have gone away from just conditioning as a concept, and then also how powerful that is, because a person can realise when they're weak, and that's something invariably they go, oh yeah, I am weak there. They don't realise until you prove it to them. Yeah. So I think deconditioning is a big issue. What are your experiences around that, Tim?
Yeah, I completely agree. We're always going to have caveats and ifs and buts here, and I could tell you many stories of where I've got this wrong. Do you know what I mean? And that's partly how we learn and get better around prescribing exercise. But having the categories there that we've talked about, and deconditioning is one of them, and being careful to tell people that you're weak, because technically if they're weak, they need 3 sets of 10 at 80% of 1 hour RM max 3 times a week. But as Peter said, some people can have weakness from central inhibition of that, and you can change their confidence, and they've got measurable strength gains in a session or inside a week. So we just have to be a little bit broader in our understanding of what's driving the altered functional behaviour, and it often is muscular components, but all those elements of the framework will contribute to muscle function and muscle performance to a degree. When there's clear deconditioning that's not linked with symptom aggravation, then we can be pretty clear on you need a strength program. And we've seen this many times where people have done strength programs for 6 months. Yes. And, I mean, tennis elbow is a classic one where we see this, where the person's got a 2 kilo weight and they're up to doing wrist extension at 2 kilos, and their physical demands of their job are 20, 30, 40, 50 kilos of lifting. Or the other end of the scale, the demands are not very high and people are going to
gym program for the sitting office job.
So I think she's probably got lots of benefits.
There's other
specific to keyboarding.
No, you often see people that don't want to go to a gym and never been, and been told they've got to go to a gym. Yeah. But people were fine before that and they never went to a gym.
They go 6 times. The 6 times they're getting supervised.
Yeah, and that's it. So I find it's probably one of the most interesting and rewarding areas for me around understanding exercise prescription parameters, but then we've got pain on top of that. So that's where the mind-body relationship and understanding those interactions for the person. But I now, as my tip for the day, if you like, around how I prescribe this, is I try and get the person on board and understand that, and I give them a degree of responsibility around this, of saying, this is the part we're working on with this, here's the warnings, as you've mentioned, around this could give you muscular pain or flare up. And obviously you need to check in at an appropriate time, depending on the level of distress or how sensitive their problem is, but giving them an understanding of what they're trying to achieve. And I have plenty of patients that make me obsolete quickly because they work it out, but there's also plenty that you do need to hold their hand and guide that carefully.
And that's the self-efficacy story all over.
Yeah.
It's the one, some people need an extraordinary amount of support, and you're working so hard to get them to take the reins. But we'll find it hard. But that's where goal setting's great, I think, as well. To say, right, I want you to make a plan. I want you to sit down and make a plan, and bring it to us, and we'll discuss it. I think that's good.
Well, I know we're all proponents of general exercise for people with pain. You want to make some comments on that?
It's critical. So I kind of see that as one of the key pillars of a good intervention is regular physical activity, like good sleep. It's just so important, and around what's the best. Patient preference is the key. Because you could design something you think is super cool, and they would hate it. And I've seen it so often. People are like, I went to the surgeon. He said, "I had to swim." I can't swim. And I hate water, and I'm not going to stick my head under it. So, well, that's a really bad idea because they will never do it. Some people have an idea of exercise as gym and lycra and mirrors. They hate that. People don't think often going for a dance. Dancing to music is physical activity. So we have to have a broader story around physical activity to go, what is it that ticks your box? What is it that can link you with social networks? Because that's really good if you can build that and work towards your goals and link it to your preference. But it's so important, and there's a dose response around that as well, obviously. That you need to do enough of it to get a benefit.
And you just made me think of the effect of body image on engaging in exercise, and that's actually quite a problem for many people. Particularly where the gyms so often say, "I go to the gym," but they've got body image stuff and they don't want it.
No, exactly.
I think we've covered that reasonably well.
Yeah, well, maybe we have. And maybe if I could change slides, it would be very useful. Has that gone backwards? Yeah, well, this is a throw. We've done a throw to a few.
So we haven't
papers.
talked about movement impairment versus
No, I think that's
control impairment.
Yeah, I think that's
which I think a lot of people get fixed on, stuck on.
And are unclear about. Go.
So look, I have thought so much about this because it's a massive point of confusion for people, and I think where it can be helpful is we see a spectrum of people's ability to move, and you'll see some people like take a neck problem where that's it. Well, that's not a normal range of movement, but you'll see other people who are like, oh my god, my neck, I can't control it, and they've got full range of movement. They don't have any strength and control of that movement. So one's clear observable barrier to movement, which we would call an impairment of movement, and one is the person's got the range, they've got big problems with the way they control it. To me, that's a very simplistic way of looking at a bit of a complex problem, but it can be a helpful way of thinking, well, you don't need to just push this person's neck into more extension because they've got the range. They need to build some control and confidence to control the neck as they move through that range. This person has got 20 degrees of movement and they're fearful and guarded when they turn. And I think that's important to understand what the driver of the restriction is. Usually neuromuscular protective guarding, which can be really exaggerated in a body part, but they just cannot move. Where the aim of the therapy will be to facilitate, de-threaten, facilitate, relax, and you can do that in a variety of ways. It could be with hands-on therapies or facilitating relaxation and movement with an exercise program. but they're slightly different goals. So I'd see it in that kind of context.
Yeah, I think gives a good understanding of it myself. Tim?
Yeah, we've talked about this with other clinicians and other teaching that we've done. And when we originally talked about this, we did have a movement impairment concept of someone with perhaps more acute, let's say an acute right neck problem where there's some local tissue response, and as that settles down, we may use some of those techniques to facilitate return to normal movement. So we kind of, initially the thinking was perhaps, well, that's more those acute musculoskeletal presentations versus the persistent pain ones where that's less relevant. But it's not as black and white as that at all, because there's plenty of acute presentations where there's no tissue response, but there's an impairment of movement, as you say, which may relate to beliefs and concern. And if you want to make something stiff and sore, tense all your muscles up around it and compress structures. So then that management, as far as manual therapy, that's potentially unhelpful, particularly if they've got high levels of pain sensitisation, as we've talked about earlier. So in that instance, understanding might be a really important treatment, breathing, relaxation, and then perhaps cardiovascular exercise might apply in that instance, for example. So they're movement impairments that require very different management. So yeah, we don't like the black and white, but it is a useful concept that if there's an impairment of movement, we need to facilitate movement, but hopefully we've got lots of tools that we would use depending on what's impairing that movement.
And being mindful that you're screening out for pathology.
Exactly.
Like a lady who had a fall, she go, I can't move. I've been trying to move my arm because you told me to keep moving. I'm going, not for this one. We'll get it scanned. You had a fracture. It's like, no, that's good to back that off for a time. But once it's healed, we're going to go for the movement. We want to make sure you don't get a frozen shoulder or a stiffened shoulder around that problem. So it comes down to that understanding of what the drivers are for that impairment. I think the other area that often gets mixed up with this is out of the manual therapy world of hypermobility and hypermobility, which is really, this is a different thing we're talking about. This is about volitional active movement. It's not about what's happening at a joint level. And it's probably usually a reflection of the degree of protective guarding, as you said. And I think that's helpful. So the degree of protective guarding can absolutely lock out your movement, or it can just influence that, alter the way that you move. It's not so helpful. So it's probably on a scale. In that sense.
And the other side of that, is around the control impairments, where, as you've mentioned, the neck's a good example. But it's I've found it helpful to think about, there's an impairment of control there, and we go, well, we need to strengthen that or get those muscles working, which is true, but there's those other factors that will impact on neuromuscular control, like you've mentioned. If someone's fearful around this, then you're not going to get a normal muscle response. So again, as we've mentioned, you could get a strength response quite quickly if you can improve their understanding or modify how they're approaching a movement. So for me, that's somewhat complicated, but it's very interesting because it makes the individual sort of strategies or the story around the person relevant.
And adequately testing the system is critical too. A recent case I saw for years as a man turn a head to the left, but could have rotated body to full rotation. So what's the driver there is not an impairment. You can spend all your life trying to facilitate that, but there's a protective guarding response that was linked to an early trauma. And that her acknowledgement of that and understanding that actually the neck could move was a critical thing to build her ability to confidence to actually relax and move into that range. So you can't just look at one movement test to determine it. You've got to look at the system from all angles.
But again, that's the skilled physical examination. Where you've got, hang on, we can look at this insidium.
Exactly.
Let's lie down and do it. Or let's support it. Or
is there a discrepancy?
It brings to mind, like, I'm doing it, not me, but let's pretend I'm doing an independent medical review and someone can only move their neck this far, and then you're saying, well, actually they can move their whole body and they've got full movement, and that can be interpreted in an interesting way in a medico-legal context as malingering or
Yeah.
exaggerating? What's your response around
So,
that?
yeah, no, I think it really is. I think we discussed this earlier. The body will respond to threat. So if you've had a motor vehicle accident, for example, and the cars come from your left, I can think of someone went to grab their child who was in the back seat. Massive threat was linked to that event.
Yeah.
And that was the key factor.
Mm.
So it makes total sense,
Yeah.
biological sense,
Yeah.
that the body in a highly stressed event goes into protective mode, and that it's like the video plays around the minute. It gets stuck on pause. It's like it's stuck in that, and something just locks into the system that you need to unravel.
Mm.
And so that idea of, well, I tricked you, you can do it,
Yeah.
versus actually it makes biological sense that the body's still protecting itself from something that was a massive threat. And that threat is exposed every time you do the thing that is linked to that event.
Mm.
So that's probably better understood through post-trauma stress or a stress response.
But that comes back to people's belief and understanding about pain, doesn't it?
It does, yeah. Exactly. Yeah. That's a good question.
We were talking about this a little while ago.
Well, there's
This
no
paper.
no rush.
Yeah.
Well, I will just mention this paper while you think of what you want to talk about next that you've forgotten.
Yeah.
I throw to this paper from Journal of Orthopaedic and Sports Physical Therapy, a couple of years old now, around the cognitive functional therapy approach.
Is that PTJ?
Oh, maybe it is, sorry.
Yeah,
You'd know better.
That paper took a long time to write, I can do it. It's probably the paper I've agonised over the most,
Yeah.
actually.
Yeah.
Just to give you some pretext, that was a number of years in the making, that paper.
Well, that's quite good because then we did the pelvic girdle
Yeah, it was a
that
lot
was a
easier.
breeze.
It was a whole lot easier.
Yeah. So there is a pelvic girdle pain one we've authored just out now, really, in the manual therapy, but musculoskeletal science and practice. So those two papers, and I'm sure there's others, but touch on those concepts quite a bit.
Mm.
Yeah.
Yeah.
Yeah. But that one in particular is a fantastic manual, or not manual, but a guide for people wanting to understand this.
Yeah, and I think what we tried to do in that paper was to take the concepts of the framework and to build it into a model of care.
Yeah.
It's to kind of go, it's from the understanding and the examination to the journey. And I think the critical thing around that is the understanding is, well, it's a challenge, but the journey is where the real work happens.
Mm.
And it's that, we have so many challenges in taking people on a journey back to, shifting their beliefs and their emotional responses, reducing their fear and building their confidence in their body. And that's an ongoing work around the world. And we're not done with that work because we know we don't get it with some people. There's so many barriers. But to us, that's a useful framework to go, what are the key elements that might be helpful from a physiotherapy perspective? And that's not in isolation, because it may be that you need the assistance of a psychologist and of pain support, pain management in that journey, but it's the journey.
Yeah.
Yeah.
It reminds me of the subtitle of the book, Tim.
Well, from knowing to doing, Darren.
Got it?
It is.
Yeah.
So I'm assuming that subtitle wasn't an accident.
No.
All right, good. Before I say goodbye, is there anything else you wanted to touch on in this movement behaviours section, or just even more broadly?
No, I think it's kind of covered many of the factors. The critical things there around movement is just, it's a behaviour.
Yeah.
Like, you don't know what it is and what factors underpin it, and so your job is to work out what it is. Never always get inside the patient's head, understand their story, see the world through their lens, don't judge them, explore, test, question, hypothesis test, so that you're never trying to wedge someone into your mindset, that you're always trying to enter their world through their mindset, and I think it gives you a much safer place to work from.
Yeah, and I think for the clinician, it's a journey for them as well to take this path, and if it's not something you're familiar with, and many people might not be, it is a journey, and you can't flick a switch and suddenly know how to do this, but there's lots of little steps that you can do, and the framework and those references help around that. Tim, anything else on the functional behaviours?
No, That's good, I think.
Well,
There's plenty there, there's plenty more we could go on about, but we're still learning and evolving this as we go, and we're lucky to hang out with people that have a shared interest and mindset that you do continue to evolve and learn from this, I think.
And where would we go to get more information on the framework?
Well, there's a website called musculoskeletalframework.net. We could go there, and there's lots of resources around the framework, but there's links to other websites on there. Pain Ed website that Peter's involved in, particularly around sharing people's stories with this, and then also
Pain Health.
Pain Health website that Helen Slater's involved in as well. Again, there's good stories, but there's good evidence-based resources. There's lots of people that do good work in this area, and we try and link with other good bits of information that help people around this.
Excellent,
Yeah.
excellent. Good.
Thanks, guys.
Thanks, guys.